Hello, I'm Dean Kereiakes, Chairman of the Christ Hospital Heart and Vascular Institute in Cincinnati, Ohio. I'm a professor of medicine at the University of Cincinnati and clinical professor of medicine at The Ohio State University. I'm also deputy editor of SCAI. I'm here today with Daniel Chamié, who is director of intravascular imaging, Yale University School of Medicine, and Ricardo Petraco, who is National Heart and Lung Institute Senior Clinical Research Fellow at the Imperial College in London, UK. And we're here to discuss an important manuscript published in SCAI. Can contrast injections cause or propagate coronary injuries? Insights from vessel and guide catheter hemodynamics. Daniel, tell us what factors are involved and what you found.
So thank you. It's a privilege to be here. Discussing our manuscript just published in SCAI. As you mentioned, can contrast injections cause or propagate coronary dissections? And we got insights from vessel and guiding catheter hemodynamics. So as a background, I think, if you look into the audience, all of us had or will have a case where we injected contrast into a coronary and we dissected during injection, or we made an existing dissection worse. So that has led to, a consensus practice recommending physicians to use contrast to avoid contrast injections in those situations, or to minimize their use, with some concerns of worsening the severity of an existing dissections or creating some. And that recommendation has practical implications in many clinical scenarios, such as spontaneous coronary artery dissections, or when you're suspecting of a stent edge dissections, or when dealing with CTO interventions, or when you're set to use an intravascular imaging and you're concerned about the potential existence of a dissection. There is some consensus that IVUS would be a preferred imaging method over OCT because you don't need to inject. So to answer those questions, we try to gain mechanistic insights into the risk of really injecting contrast into a coronary and causing injuries by analyzing coronary hemodynamics during injection at multiple points inside the vessels and also inside the guiding catheter. We conducted a prospective single-arm multi-center study in 4 centers in Brazil, Mexico, and the United Kingdom. And we recruited patients that were clinically indicated for pressure wire assessment during either a coronary angiography or a PCI. And we included only non-culprit coronary arteries without any angiographic luminal stenosis, or if there was any stenosis, that was a non-flow limiting stenosis according to the physiological assessment, or after stenting culprit lesions and, don't leaving any physiologically significant lesion behind. And we excluded severe lesions or physiologically significant lesions. So that's the experimental design, very simple. We used a pressure wire inside the vessel. We did a continuous 1-minute recording involving 10 seconds of resting, recording the moment that we injected when you lose the PA pressure by opening the 2E, and then you see here some hyperemia caused by the contrast, and then restoration of resting flow up to 60 seconds. So that was the experimental protocol that we did in 5 positions, 4 inside the vessel. So distal, whatever vessel you analyze, distal, mid, proximal, and then at the guiding catheter tip and inside the catheter. And we did that for all analyzed vessels. And those are the results. So you see that in the distal, mid, or proximal vessel locations, there was minimal increase in pressure during injection, but a much greater rise in pressure inside at the guiding catheter tip, and a much higher inside the catheter. In this graph, we plotted the difference in peak pressure as a function of guiding catheter length, distance, and the target vessel analyzed. And I think the best way to interpret this is starting from the left to right, where we are inside the catheter in the negative position here. So you see that we generated a lot of pressure to overcome the resistance caused by the catheter. But by the moment that we exited the catheter tip, there was minimal rise in pressure inside the coronary. So this excessive rise in pressure we created to inject contrast mainly dissipates upon exiting the catheter and with minimal transmission into the coronaries. We also analyzed the change in pressure according to the mode of injection. From the 4 sites, 2 sites, actually, we randomized injections to be taken manually or with the assistance of a pump injection. And in the other 2 sites, all injections were required manually, in a sense that 60% of injections were manual and 40% were pump injected. The total contrast volume for manual injections was around 3.8 and 4.8 for pump injections, and those are the settings that we used. And you'll see that regardless of where you are into the coronary or into the catheter, there was no significant difference in the rising pressure achieved either with manual or pump injections. And this is one case example. So starting from the inside the catheter position, you can appreciate that at the moment of injection, we generated a very high pressure up to 300 millimeters of mercury. That is transmitted still to the guiding catheter tip, but once we get into the coronary, you see minimal transmission or no significant change from the moment we injected to the resting phase. And more importantly, you can appreciate that the morphology of the PG pressure is the exact same as resting. So there's minimal transmission with no change in the pressure morphology, as we could see at the tip of the catheter or inside the catheter. So we concluded saying that the hydraulic forces needed for contrast media injection during percutaneous procedures do not lead to a clinically significant increase in coronary pressures beyond the segments very close to the coronary catheter. And although care should be taken during injections in cases of very proximal dissections or with catheter-induced pressure damping, it is unlikely that routine contrast injections would cause or worsen coronary dissections beyond the region close to the catheter. Thank you.
Well, that's excellent. And clinically, it's been my perception, over decades, that the likelihood of causing a catheter dissection with an angiographic catheter in particular is inversely proportional to the extent of atherosclerotic disease in the vessel that you inject. So normal vessels, for example, are more likely, whether it's for coronary reactivity testing, alcohol septal ablation, things like that. And I think we've discussed that previously a little bit. It's no different, though. Are they coronary versus atherosclerotic? How would you explain that observation, which I think is real?
Yeah, no, I agree. And that's also our practice to observe more dissections in normal vessels than diseased vessels. And I think the major reason is because atherosclerosis kind of prevents or creates resistance and prevents dissections from propagating. It doesn't mean that you're not going to get a dissection, but if you have it, it's concealed and handled by the disease. And that's one of the reasons we excluded severe lesions. We wanted to make sure that we would not have obstruction to the pressure transmission down the vessel. So we could explore, what is the pressure transmission once we inject into the catheter and see how long it goes into the coronary. So that's one of the explanations why we excluded significant lesions or flow limiting stenosis.
Got it. Well, Ricardo, SCAD, spontaneous coronary artery dissection, we see that frequently, and it's intravascular imaging, and particularly OCT, can be very helpful in that diagnosis and even risk stratification. So how do you resolve that doing angiographic injections? Do you think that it's not a problem, even though current guidelines may recommend against using OCT and contrast injections? What would you say?
Yes, very good question. And I think there are 2 elements here. One is just instrumenting the artery itself, and they need to put a wire down, an OCT catheter or an IVUS catheter. There is a risk with doing that. Now, people get very worried about the fact that we're injecting, doing OCT measurements, and even doing angiography in the phase of a dissection. There's this intuition of using that force that we are doing injection and transmitting that pressure into these dissected elements of the vessel. And I think that what this data here shows is that Yes, of course you have to be careful. Of course you have to be careful when instrumenting any vessel with a suspected SCAD. But if you think that it's important to make that diagnosis and to use intravascular imaging and OCT or to take further pictures, it's extremely unlikely that you're going to propagate that dissection, providing that it's distant enough from the catheter tip. So you're not going to be transmitting that force to the mid-proximal distal vessel. And you should be confident that if you think the diagnosis is important, contrast injections are safe, providing it's done in a sensible way in these patients.
Wow. It sounds like both you guys are saying that it's all about technique at the end of the day, making sure your catheter tip's free, you're coaxial with the vessel.
And one tip as well, one tip we take from coronary physiology work when we're trying to make sure that the pressure waveform is normal before we measure FFR or any index, is it very useful here as well. Because in any event of the catheter being over-engaging or inside a dissection flap or very likely transmitting that pressure distally, you're looking at your pressure waveform, your aortic pressure is very important. And do not inject unless you have a normal, healthy proximal waveform. This data also highlights perhaps a mechanism of why we get VF sometimes when we inject in a very damped conus branch in the right coronary artery, is that we are transmitting all that force into a tiny little branch directly into the coronary circulation. And again, it's all about looking at the waveform and ensuring that you have a healthy, normal dicrotic notch, and then it should be safe to inject in situations like that.
Mm-hmm.
Yeah, I'd like to add to that, if you look at the volumes we injected, there are very small volumes of contrast, right? So we did a 3.8 cc's in manual injections, 4.8 pump injections. And my first comment would be, you don't need much contrast to get a good coronary angiography. But even to inject small amounts of contrast, we generated very high pressure, up to 300 millimeters of mercury. And that phenomenon that we just showed, that this high pressure change dissipates once it exits the catheter, only happens if you have a coaxial pre-catheter tip. If, as Ricardo mentioned, if we have a damped pressure or if your catheter is touching the vessel wall, that very high pressure we cause will propagate into the wall and increase the risk of injury. So as you said, it's all about the technique, right? So you asked about the OCT for SCAD, and although the volume we used with pump injections or manual injections in this study were much smaller amounts that we used for OCT acquisition, the pump settings we used are pretty much the same. We used 300 PSIs and about 4 cc's per second of flow rate. So it's pretty much what we usually use when we do an OCT with pump injections, right? And the only difference is the amount of contrast you're injecting during that time. And that we just proved that regardless of the volume, if you're not dampening the pressure, that pressure should dissipate and the contrast should flow down the vessel without any constraint.
And just to add that another line on it is that a lot of people reacted to our paper, particularly CTO operators, saying, I'm still concerned about it. And absolutely, CTO is one of those scenarios where you are inside a contained volume of a vessel, and all those concerns apply. You should not be injecting in a situation where you're not sure where you are. And so all our data do not apply to scenarios where you're potentially in a false lumen or you're trying to cross back into the normal vessel. So CTO operators should be reassured, actually, that what you're demonstrating here proved their point, that if you're inside somewhere, that pressure will be transmitted to it, and you should not be injecting it.
Yeah. But are there any other factors involved? Shear stress, et cetera? Is it all pressure? And you can see the pressure decay in figure 4 of your manuscript. It just drops like a rock beyond the tip of that catheter. Is there anything else that can be operative here?
Yeah, I think that it's important to highlight it as well. This is a mechanistic study that we are isolating one element of the energy that we use to transmit sort of a pressure distally. Causes of dissections, particularly SCAD, are very multifactorial, depends on the coronary anatomy, tortuosity, vessel fragility. So we are not saying here that pressure is the only cause of dissection in the arteries. What you're trying to say is in any scenario, our contrast injection will not lead to any worsening of that injury that could be transmitted via pressure through our forces during the injection. That's the only thing we're saying here. So we have to be very humble with our conclusions. Yeah.
Was the contrast standardized across your multi-center trial? I mean, the contrast that was actually injected, what were the thoughts on that as a variable?
Well, so what we're, and I think we can make, a clear statement that we're not propagating that we should be injecting contrast like crazy. So we're very conscious about the amount of contrast. What we're saying here is that if you are applying the proper technique, injecting contrast should not increase your risk of dissection or propagating it. Or if you're in doubt of something and you want to use intravascular imaging, OCT shouldn't be a concern, provided you apply the proper technique. That said, we should always be mindful about the contrast volume. So, just inject whenever you need and minimize contrast at all costs.
Daniel, Ricardo, can you give us several summary bullet points of your findings just to wrap it up?
Yeah, I think, applying proper technique is key, and be mindful of contrast use, but whenever you feel that contrast injection is necessary for, a diagnosis or an unclear situation where you need intravascular imaging, applying proper technique would be, you shouldn't have any concern of injuring the vessel or propagating the dissection if you apply proper technique. Yeah.
Ricardo, anything that you would add?
I would just bring my physiology hat here to the discussion and say, watch your waveforms and do not inject if your waveform is not looking healthy.
That's a good one.
Not.
Yeah.
And I think that applies to physiological assessments, to when you're injecting the right coronary artery, particularly, or if you suspect a dissection. So watch your waveform. And if your technique is good and your waveform is healthy, you shouldn't be worried that your pressure will be transmitted distally.
Yeah, I think that's a message. It's all about technique at the end of the day. And so I want to thank Daniel Chamié and Ricardo Petraco for being here with us, and to thank SCAI for giving us this opportunity to do these conversations and really delve more deeply into papers that are recently published in SCAI that can make a difference in our clinical care of patients. So thank you for being with us.